Myself, Dr. Raktim Mukherjee, Assistant Professor and Head of the Department, Shri P. M. Patel Institute of PG Studies and Research in Science, affiliated to Sardar Patel University, Anand. The title of my today's video is Alzheimer's disease. Some of the salient features first. As an introductory note, Alzheimer's disease is a progressive neurological disorder that causes the brain to shrink. Shrinkage we mean by atrophy, and eventually the brain cells would die. It's one of the most common forms of dementia. What is dementia? It's a continuous decline in thinking, behavioral and social skills, that is cognitive function. There is a continuous decline in thinking, behavioral and social skills, and ultimately it affects a person's ability to function independently. You always require a nurse or a caretaker to take care of the person. This disease has financial implications because since the patient has to visit hospital too many times, it's a burden on the healthcare system. Moreover, people are not happy with the disease, the normal life is affected, not only the person or the patient, also of the family members or dependent person. So, it is an emotional impact as well of family as well as the caregivers of the patient. We go to the history of Alzheimer's disease. It was Alois Alzheimer, a German psychiatrist and neuropathologist. This is his photograph. Alzheimer is credited with identifying the first published case of presenile dementia. This was when Kraepelin, the person on whom he interviewed, would later identify as Alzheimer's disease. There are environmental and genetic risk factors for this disease. The strongest genetic risk factor is from an allele called as APOE. APOE stands for apolipoprotein E, a possible MCQ for your examination. As apolipoprotein E is one strong genetic marker. There are other risk factors such as anyone having history of head injury, someone having clinical signs of depression, patients already suffering from hypertension, systemic hypertension, high blood pressure. The disease can be also associated with some of the other features, like most common one is amyloid plaques, neurofibrillary tangles, and loss of neuronal connections in the brain, right. Of course, you need to understand and visualize what are amyloid plaques and what are neurofibrillary tangles. So, I have a diagram for you. Amyloid plaques and neurofibrillary tangles, this is a normal person's neuron, whereas a patient who is suffering from Alzheimer's, you have neurofibrillary tangles and amyloid plaques, depositions that are formed. These are the classical hallmark features of Alzheimer's disease. What is the prevalence of this disease? Total, as of this data, whichever I have depicted, is 2020. Total 5.8 million patients. Age group 65 to 74, 1 million, that is 17%. 75 to 84, 2.7 million, 47%. 85 plus, 2.1 million, 36%. So, maximum patients are in the age group of 75 to 84, suggesting this is a disease which hits only the elderly population. What are the risk factors for development of Alzheimer's disease? Increased age, your age is more than 65 years, you are suffering from hypertension, you are hypercholesteremic, more cholesterol, coronary artery disease, you are already suffering, you are having comorbidities such as diabetes. There are other risk factors such as genetics, person who smokes or drinks alcohol, increase in plasma homocysteine, patients with chromosomal abnormalities such as Down syndrome, and patients who already have mild to moderate amount of cognitive impairment. They are all at greater risk of developing Alzheimer's disease. Some of the multiple cognitive deficits in Alzheimer's disease, 4 common terms and terminologies often asked in MCQ again. Multiple cognitive deficits of dementia in Alzheimer's disease. First, aphasia. Aphasia is deterioration of language function. Second, apraxia. Apraxia means impaired motor function. Third, agnosia. Agnosia is inability to recognize name of objects. Fourth, executive functioning, that is to inability to think abstractly. So, creative as well as cognitive functions are lost since an Alzheimer's patient suffers from dementia. Alzheimer's disease progression. What are the different stages of Alzheimer's disease? There are 3 basic stages: a mild stage, a moderate stage, and a severe stage. Mild stage implies memory loss, language problem, mood swings, personality changes, and diminished judgment. Whereas when the symptom progresses to moderate, the person has behavioral and personality changes. The patient is unable to learn or recall, that is long-term memory is lost. The patient keeps on moving, is always agitated, always aggressive, appears to be in confusion, and always requires medical assistant or healthcare assistance. When the disease progresses to the last stage, that is severe stage, patient's gait or standing position is affected. The patient suffers from incontinence. Incontinence is urinary incontinence, that is motor disturbance. The patient becomes bedridden. They are unable to perform some of the common everyday lifestyle changes, and the patient always needs long-term medical care. That is Alzheimer's disease late. This is from your book, which is there from Sardar Patel University. I am not repeating, but more or less normal aging, you have preclinical, you have MCI, that is the mild symptom, and finally the clinical Alzheimer's disease. So, no symptom in preclinical, no symptom, prodromal, mild symptom, and clinical, very severe symptom. Which are the symptoms in mild and severe? Memory loss, cognitive impairment, onset of Alzheimer's pathology, and finally progression to Alzheimer's pathology. Alpha beta aggregation or deposition, that is amyloid plaque, tau protein aggregation, impaired brain metabolism and synapse loss, synaptic plasticity, and neuronal loss or brain atrophy. These changes can be determined by structural magnetic resonance imaging or MRI. Impaired brain metabolism can be tested using FDG, fluor D-glucose, in PET scanning, positron emission tomography. P2 aggregation can be, these are the ones with immunohistochemistry you can determine. Now I come to the very important part. This is where I will slow down, I will explain. This is the only role where teacher's role is really important. Pathophysiology of Alzheimer's disease. Just like in Parkinson's, what is the pathophysiology in Alzheimer's disease? First we will go with neuropathology. This is the brain region, the frontal lobe, the parietal lobe, the occipital lobe, the hippocampus. Hippocampus is for memory, and temporal lobe. Okay. And you have the function also. Parietal lobe is for process touch, taste and temperature. Occipital lobe process visual information. Hippocampus forms and process memories, good memories and bad memories both. And temporal lobe process hearing, memory, language, emotions. And frontal lobe helps to control movement, involved in personality, behavior, planning, decision making, who you are, that is self awareness and attention. Now what happens in Alzheimer's? There is a loss of neurons and synapses in cerebral cortex and certain subcortical regions, cerebral cortex and certain subcortical region. This loss results in atrophy of the affected region. That region gets atrophy. There is a degeneration in the temporal lobe and parietal lobe and parts of the frontal cortex. Already all cortex are there, and cingulated gyrus. All these areas are affected in Alzheimer's disease. Which are the areas? Temporal lobe, the parietal lobe, parts of the frontal cortex and cingulate gyrus. These are all affected by Alzheimer's disease. Now something to reckon from with diagram. This is your healthy brain, cerebral cortex, lateral ventricles, everything is visible, the hippocampus. Whereas in Alzheimer's disease, what happens? There is an atrophy of the cerebral cortex. The cerebral cortex undergoes atrophy. The ventricles, here the ventricles were quite small, here the ventricles become large ventricles. And there is also an atrophy of the hippocampus, Here the hippocampus was very prominent, here the hippocampus wastes away or wears away, that is atrophy of hippocampus. So that was the neuropathology of Alzheimer's. Now something for writing in examination based on understanding. Neuropathology of Alzheimer's disease. Both alpha beta amyloid plaque and neurofibrillary tangles are clearly visible in microscopy in the brain of the affected patients of hippocampus. The plaques are dense. They are mostly insoluble deposits of beta amyloid peptide and cellular material outside and around the neurons. The tangles, when I say tangles, neurofibrillary tangles are aggregates of microtubule associated protein, that is tau. Tau is microtubule associated protein. We have studied cytoskeleton in first semester. This has become hyperphosphorylated. Hyper is extra phosphorylation, and after it becomes extra phosphorylated, it can accumulate inside the cell themselves, and that leads to neuropathological changes. What are the gross pathological changes? 3 gross pathological changes are cortical atrophy, I just showed with diagram, enlarged ventricles, again I showed by diagram, and basal ganglia wasting. The basal ganglia keeps wasted and atrophy takes place. These are the 3 basic pathophysiological changes. How do you see under microscope? What are the observations? Microscopic observations. There are changes in the proteins of the nerve cell of cerebral cortex, accumulation of neurofibrillary tangles, granulovascular degeneration, and loss of cholinergic nerve cell. This is very important. Once your cholinergic nerve cells are lost, patients with Alzheimer's disease will have memory function and cognition problem. Something you have told them just 10 times, still they will forget, and they become very helpless. They are trying their level best to remember, still they cannot remember. That is Alzheimer's. The cholinergic nerve cells are lost. It leads to memory function and cognition problem. Now we come to our topic. Medical biochemistry is the subject's name, and so we study the biochemistry of Alzheimer's disease. What are the biochemical basis of Alzheimer's disease? There are two key proteins, MCQ, exam MCQ, which are the two key proteins which underlie plaques and tangles of Alzheimer's disease, and the two proteins are beta amyloid, one protein, and another protein is tau protein. Whenever there is a mutation in the APP, that is the enzyme amyloid, you have amyloid precursor protein APP. Whenever there is a mutation in APP, this APP mutation will lead to the faulty processing of enzymes such as gamma secretase, and this causes familial Alzheimer's disease. Also, there is a mutation in tau, and this mutation in tau causes familial frontotemporal dementia. The mutation in tau causes familial frontotemporal dementia. So, beta amyloid, this is the diagrammatic representation. You have the APP enzyme protein, and what the enzyme does, the enzyme will clip this peptide, and once it is clipped, you have deposition of beta amyloid plaque, and these beta amyloid plaque gets deposited. 90% of the problem in Alzheimer's is because of this beta amyloid plaque, and lots of research has been done. We very well know the role of beta amyloid plaque in progression or pathological basis of Alzheimer's disease. Now, what is improper APP processing? Let us see, these are some important areas of my talk. APP, amyloid precursor protein, this is an integral membrane protein expressed in many tissues, and this is concentrated in synapses of neurons. This protein is implicated as a regulator of synapse formation, neuronal plasticity, and ion export. This protein is also the best known precursor molecule. Why this precursor molecule? The proteolysis of this precursor molecule will generate the beta amyloid plaque, that is abbreviated as A beta, that is beta amyloid plaque. Now, what happens? First, overview followed by detailed explanation. This is your amyloid precursor protein. Under normal circumstance, you have the enzyme alpha secretase. What the alpha secretase does, alpha secretase will break amyloid precursor protein, and therefore, you do not have plaque formation. However, in pathological condition, in patients who are amyloidogenic, that is those who are proneness to develop Alzheimer's, instead of alpha secretase, you have the beta secretase and gamma secretase, and gamma secretase and beta secretase will cleave the side chains, leading to the deposition of amyloid beta plaques, and so lots of amyloid beta plaques deposit, and this eventually forms what I showed just now, the beta amyloid plaques that keeps depositing. Now, in detail, neurotic plaques, in general they are cleared by beta secretase and alpha secretase. Whenever there is a mutation of amyloid precursor protein in chromosome number 21, MCQ for exam, there is an increased production of amyloid precursor protein. This increased production of protein will lead to more amount of amyloid protein. More amyloid protein, more accumulation of precursor, and this precursor can be directly neurotoxic, and it can lead to Alzheimer's disease. Under normal circumstance, the alpha secretase, as I showed, will cleave this particular APP so that the plaques are not formed. However, under pathophysiological condition, instead of alpha secretase, you have beta secretase and gamma secretase that will lead to more and more deposition of beta amyloid plaque. Now, what is this very important, many research papers are there. What is this amyloid hypothesis in Alzheimer's disease? You have genes such as PSEN1 and PSEN2 or FAD mutation. This is from Nature Drug Discovery I have taken. Positive effect of these mutations will, and as well as APP FAD mutations or trisomy of chromosome 21 MCQ, which chromosome is involved, trisomy of chromosome 21. Any of these aspects will lead to the APP. APP will then have alpha beta 42 aggregation. You will have soluble forms of oligomeric alpha beta and the deposited amyloid beta peptide. Together they will lead to aggregation of stress, the PHF formation, neuronal dysfunction and death, and eventually beta amyloid precursor or amyloid plaque leads to memory or cognitive impairment, that is dementia. Dementia results from amyloid plaque. This is the highlight of amyloid hypothesis in Alzheimer's disease. Of course, this time you have MCQ, but otherwise in exam a short question is asked. Write a short note or describe what is amyloid hypothesis in Alzheimer's disease. Now, we come to the last part of the lecture, that is diagnosis and treatment. Pathophysiology part we complete. Now, how to diagnose Alzheimer's disease? First, you have to take detailed history of the patient. You have to rule out any other neurodegenerative disease such as Parkinson's or Huntington's and all those. You have to take the case history, and case history will tell you whether the patient is suffering from Alzheimer's. You also have to take information from the family and friends of the patients, whether they require health care or care at home. Some of the laboratory tests can be carried out to rule out vitamin B12, cyanocobalamin and folate deficiency. You have to rule out hypothyroidism with thyroid function tests. You have to go for CBC, total blood count, serum electrolyte, the LFT, that is lung function tests. You can also go for certain diagnostic tests, other diagnostic tests such as CT, computerized tomography, PET scan, positron emission tomography or MRI scan, and all these scans can help in diagnosis. What are the biomarkers in Alzheimer's disease? Again, MCQs can be asked from this area. There are various biomarkers in Alzheimer's disease. Some of the biomarkers are biochemical. Biochemical markers are CSF, cerebrospinal fluid. These are blood based marker. Then you have neuroanatomical marker, that is CT scan and MRI, neuroanatomy. What are the anatomical changes? Then there are metabolic markers. Metabolic markers can be through PET scan and SPECT scan, positron emission tomography, and SPECT is single photon emission computerized tomography. Then you have genetic biomarkers such as APP, amyloid precursor protein, PSEN1, PSEN2 and apolipoprotein 4, APOV4. Then you have certain neuropsychological markers such as episodic memory, whether the patient is forgetting recent past, what is the level of attention, whether the executive functioning is proper. These are some of the neurophysiological changes. Overall, the biochemical basis of markers can be there, neuroanatomical basis, metabolic basis, genetic basis and neuropsychological basis. Now, we come to the last part of our talk, how to treat Alzheimer's patient. Just like we dealt with the Parkinson's we replace dopamine. Likewise, how do we treat Alzheimer's patients? First of all, let's be a little depressed by learning that there is no complete cure for Alzheimer's. There is no permanent cure for Alzheimer's. You can improve the symptomatic decline by improving cognitive function. You can improve daily activities and behavior. Some of the current therapies are: 1, you can arrest the neurodegenerative molecular process. So, lots of research is needed for current therapy. I will just, to save time, I will be just highlighting with the treatment in just 2 slides. One, amyloid precursor protein, just now what we studied, you have gamma secretase action. So, because of gamma secretase, the amyloid beta generation takes place and that results in amyloid plaques. So, what you can do, you can use gamma secretase inhibitor, no secretase, no formation of amyloid plaques. Likewise, once amyloid beta plaques are formed or neuritic plaques are formed, or once tau protein is formed, hyperphosphorylation, what you can do, you can use antioxidants or PPR gamma agonists. This will block oxidation. NMDA antagonists to check or control excitotoxicity. Statins and non-steroidal anti-inflammatory drugs, painkillers to control inflammation. You can use estrogen also to control inflammation. Likewise, you can use heavy metal chelator, because beta amyloid plaque, lots of heavy metals are there. You can use heavy metal chelator, iron, transition metals such as chromium. All these heavy metals can be chelated so that you do not have alpha beta amyloid plaque. Likewise, it causes neuronal death, deficit in acetylcholine. So, since acetylcholine deficit is there, you can use acetylcholinesterase inhibitor, or you can use nicotinic agonist, or you can use 5-hydroxytryptamine antagonist. Any of the 3 things you do, you can control the deficit in acetylcholine, the deficit in serotonin, and the deficit in norepinephrine. Together, by modulating the action of various drugs, you can bring effective control. I am not saying complete cure, effective control on Alzheimer's disease. Now, what are the drugs used in Alzheimer's disease? Some of the approved drugs where the roles are very much established. One is cholinesterase inhibitor. Cholinesterase inhibitor, you can use donzepizil, this will inhibit cholinesterase. Then you can use rivastigmine, or you can use galantamine. Likewise, you can use NMDA antagonists such as memetin, nicotine receptor agonists such as 4-hydroxy-GTS21. You can also use gamma secretase inhibitor, that is semaglutide, 5-hydroxytryptamine 6 antagonist SB271046, statins which you have studied in the atherosclerosis, simvastatin, pravastatin, atorvastatin, rosuvastatin you can use. You can use heavy metal chelators, you can use estrogen, you can use anti-inflammatory drugs, especially NSAIDs or steroids. Some of the experimental drugs, some of the plant products, ginkgo biloba, you can use vitamin E, already established, melatonin, and you can use pioglitazone, which is a PPR gamma agonist. All these drugs, still experiments are going on, but some promising results are there using all these agents which are still under evaluation. Now, before we end, we should know what are the future research in Alzheimer's. The future research are symptomatic treatments such as nicotinic receptor agonists or antagonists. Lots of research is going on. Pharmaceutical companies are designing new drugs. Serotonin receptor agonists and antagonists, that also you are designing. Some of the disease modifying treatments such as any research which can take care and it can prevent amyloid formation, the entire biochemical and molecular pathway. Beta and gamma secretase inhibitors, you design new drugs which are beta and gamma secretase inhibitors without side effects, inhibit the beta aggregation. You can also inhibit tau phosphorylation inhibitors, so that the tau protein which has a role in Alzheimer's, that also can be taken care. Again, you can always go for do it yourself approach. This is very common. This is something where you do not need medication nor you need healthcare assistance, you can do it yourself. And what is do it yourself approach? Diet control, of course, patients can control diet. You can use exercise. You can control your emotional and physical stress, that is stress control, and you can go for herbal remedies. So many herbal remedies are there. Some of the things are turmeric, garlic, allicin, turmeric. You have the turmeric. What is the active ingredient of turmeric? Anyone? Okay, you can find it out. That can be your homework. Finally, to conclude, cholinergic agents initially improve and transiently maintain cognitive abilities in patients with mild to moderate Alzheimer's disease. However, the cognitive abilities worsen over time. Once it worsens, it indicates that treatment should not stop, but you can always delay the progression of Alzheimer's disease. There are new treatments that are available which can maintain the cognitive ability, and this can also be a SOS to stop the progression of the disease so that you can arrest the disease at an early stage. And finally, a big thanks to all of you for attending.